Janet Barnes, and I'm the director of the Illinois Cancer Care Foundation. I want to thank all of you for joining us this afternoon and being with us. We really appreciate your attendance at this event. First, I'd like to recognize a couple reps that are with us today from the practice, and hopefully you were able to talk to them one-on-one, and hoping that they were able to answer any questions you might have. But from our research department, Kirsten Schmidt, back there, and then probably most of you know Carrie Jones, and so we appreciate your being here. Michelle Rice from our pharmacy was here earlier and needed to head out this afternoon, but feel free to pick up any of the materials that they've left at the table and take it with you. And again, if there was someone that you know that was planning to come and couldn't make it today, feel free to take an extra one for them as well. Again, I want to acknowledge the Amgen Pharmaceutical Company. They were instrumental in helping us fund not only this program, but 5 other programs similar to this that we've hosted throughout Central Illinois. They provided us with a grant a couple of years ago, and the major focus for that grant was to provide information to our citizenry about the importance of clinical trials in cancer treatment. And this is kind of the tail end of that grant, whereby we're able to kind of come to you in the community where you live and present information about cancer treatment. And so we want to acknowledge them for their financial support for this program. Just a few things before we get started with the formal remarks for the afternoon about our foundation. Each of you, I think, on your table has a little brochure. Hopefully you'll take this home and read a little bit about what our foundation does. But our major focus is to support patients and their families throughout central and western Illinois. Our primary goal is supporting clinical cancer research for our patients, and that entails our funding the shortfall between what the National Cancer Institute gives us each year and what it actually costs to run that program and have staff available to work with all the patients and follow them through their clinical trials. So as an example, this year we'll probably write a check for about $350,000 to support that program. We also realize that the best way to prevent cancer is through patient screening programs, and we have a number of programs that we provide funding for, especially in the areas of hereditary breast and colorectal cancer. And we're funding some screening programs for families that are positive for genetic types of cancers, and maybe have family members that would also like to be tested for those genetic markers, but for some reason there's a financial barrier to doing that. Our grants will help support family members in being tested, and again, helping them to have kind of relief from uncertainty in terms of their health care, and then be able to make decisions about how they want to be treated and followed moving forward. On a related note, we also provide funding for genetic tumor sequencing, and again, there are a number of different types of cancers where patients may be candidates for targeted therapies, which obviously can be offered close to home, and don't have to travel out of the area for those therapies. And then these new types of treatments, I know Doc will talk a little bit more about them, they really work to kind of disrupt the signals that cause cancer cells to kind of divide and multiply, and it helps you to fight your cancer with greater precision and hopefully with fewer side effects. So we're involved in, again, helping patients be able to fund that genetic tumor sequencing. We also do have a couple of programs that support our patients and their families during the holiday times. We have a program called Trust and Hope, and we provide Thanksgiving meals to families, as well as holiday gifts to the children of terminally ill families. And again, it's a program that's been going on for many years, and we have a wonderful cadre of volunteers that help us go out and deliver these meals and gifts all throughout central and western Illinois. So we're proud to be able to offer that as a service to our patients and their families. And I think one of the important kind of closing remarks is all the funds that are raised through our foundation stay 100% local in central Illinois to provide support for you and your families. Just a couple of kind of housekeeping things here. Each of you probably have a little evaluation card. If anybody was awake this afternoon, you realize it says Bloomington. We know that we're in Pekin today, but it does have doctor's name on it. Yes. Mm-hmm. Oh, it does not have.
Yes, it
does.
does.
Okay. I guess I'm looking at it wrong. But anyway, we got the location wrong, but we know where we are. But if you wouldn't mind, as you're going through this afternoon, to fill that out for us, because it really does help us kind of fine-tune our programs and help us better serve you. So if you wouldn't mind taking a few minutes before you leave. And then you also have a little blank 3x5 card. And what that little blank 3x5 card is, as you are listening to Dr. and Carrie give their presentations, feel free to write down questions you have. And then once they've made their formal remarks, we'll go around, we'll collect these so that you can be anonymous. And then we'll take questions. Doc and Carrie will go through the questions and we'll answer them. So let me just briefly introduce, I know most people know Dr. and Carrie, but we'll do some formal remarks. Dr. joined Illinois Cancer Care in 2002, and she received her undergraduate degree from Princeton University, and then she received her Doctor in Medicine degree from the University of California in Los Angeles, also known as UCLA. And there she also completed her internship, residency, and fellowship in hematology and oncology. She is what we call triple boarded. She's boarded in internal medicine, hematology, and medical oncology. Carrie Jones, our advanced practice nurse, she's been with Illinois Cancer Care since 2003. She received her undergraduate degree in biology from the University of Illinois at Champaign-Urbana. And also has a bachelor degree in nursing from the St. Francis College of Nursing in Peoria. And she has a master's degree as a family nurse practitioner through Mennonite College of Nursing at Illinois State University. So I want to thank them. I think we'll start with Doctor's presentation, and then we'll go on with Carrie, and then we'll take your questions.
Thank you very much for being here and supporting this program. I'm very glad to see so many familiar faces and non-familiar faces. And my job, when Janice asked me to give this talk, she said, Doc, could you just talk something about advancing cancer treatment? Well, I asked her how long is the talk, and she said, 20 minutes. I said, forget it. That's how much we talk about, even with breast cancer. So I'm just going to focus on breast cancer, but this is just one of the examples of what we have been through during the last 50 years in treating breast cancer, and then from that you can extrapolate what has been going on in the cancer world. So if I open a textbook and say, what is breast cancer? And this is the kind of definition you're going to have. Breast cancer is a heterogeneous, phenotypical, diverse disease composed of several biologic subtypes that have distinctive behavior and response to therapy. What is this? All it means is that breast cancer, not all breast cancer is the same. It has many different phases, it has different types, it has different behavior, and different type of treatment. So keep that in mind. So what would influence us, the outcome of breast cancer treatment depends therefore on many factors. The first thing that you see on the list here, the lymph node status. Our patients go through surgery. Everybody asks how many lymph nodes you get. Or is that a big metastases in the lymph node or little metastases in the lymph nodes? We also look at the tumor size, 1 centimeter, 2 centimeter. We look at the tumor histology. Now, in the past, about, I would say 20 years ago, the lymph node status and the tumor size basically is the key to for us to determine whether this patient needs chemotherapy or radiation therapy and so on and so forth. But during the last 15 years, the histology and the biology of the tumor is really what drive the treatment. What kind of biology that we're looking at? In breast cancer, we're definitely looking at the estrogen receptor status, the progesterone receptor status, and the HER2/neu. Majority of breast cancer is driven by estrogen. Two big risk factors for breast cancer is age and being a woman. Men get breast cancer too, but the ratio is 1 out of 100, whereas in women is 1 out of 7 or 1 out of 8. One of the other factors that we later discovered is the HER2/neu status. This basically is a transmembrane protein that expressed in only about 20% of women with breast cancer, and is a signature for a very aggressive breast cancer. It is important because we do have specific therapy for a patient who has this type of breast cancer. Then we look at, does the patient have local disease just in the breast, or they have extensive disease that's outside the breast? What is their performance status? Are they able to take care of themselves? Are they able to handle the chemotherapy? Are they bedridden? And their age and comorbid condition, do they have heart disease? Do you have diabetes? All of these factors are very important to the outcome of breast cancer treatment, or all of the other type of cancer treatment. So I figure I'll just bring up a random case. I mean, I made this up because this is very common. So it's for me to easy talk to you about the treatment that we have these days. Susan is a 52-year-old perimenopausal woman, meaning that she's around the age of having period, still having period, but start having some symptom of menopause. She's diagnosed with stage 1 breast cancer, very early stage breast cancer. Her tumor is only 1.8 centimeter, and her tumor is estrogen receptor positive, progesterone receptor positive, and HER2/neu negative. She had partial mastectomy or a lumpectomy and sentinel lymph node dissection. So what kind of treatment does Susan need after surgery to reduce her risk of recurrent disease? Well, I'm sure all of you probably heard this very, very common statement after your surgery. Your surgeon sometimes will say, I got it all. And you come home and say, yes, I got it all. And then by the time you go to that Le-Lindqwister and she said, no, we don't know that yet. And then you get anxious, you sweat. So what do you mean? Well, I don't think any doctor, from surgeon to pathologist to oncologist, can convince you or really can tell you for sure if you are completely cured. I don't mean to be pessimistic, but once you're diagnosed with breast cancer, you're always at risk for recurrent disease. Whether the risk is 1%, 0.5%, or 20%, so everybody would have a risk. And our job as oncologists and a healthcare provider is to reduce that risk and to ensure that you will be able to enjoy a longevity just like any other normal woman. So, so how do we decide who needs further treatment outside of the surgery? We look at the tumor histology, the biology of the tumor. We look at the tumor size, the nodal status, and again, the biology. So in the past, when we don't have a lot of technology, somebody has invented these tools. And one of the most commonly used is called the Adjuvant online. It's developed by Dr. Graflin at University of Texas. And what it is that you take your information, your name, well, not name, but your age, your tumor size, the lymph node involvement, ERPR status, HER2/neu status, you put it in the computer, and the computer just randomly spit out a number. Okay, your risk of recurrent disease is 10%. And then the doctor will look at that risk number and will talk to you, wow, I think you need chemotherapy, no chemotherapy, and so on and so forth. There's other tools that are less used, like Cancer Math or the FIN projects, and I have not, outside the Adjuvant online, I have not used the other tool yet. So in the last 10 years, I think you probably have heard about the genetic profiling. This is, I think, is one of the major advances that we have during the last decade of how we treat breast cancer. The test is called the Oncotype DX test. It's a very neat test. They take the tumor that removed from the breast of the patient, and we send it to the special lab, and that special lab will look at that tumor and figure out what genetic mutation does that tumor has. They can only analyze 21 gene mutation. You could have all 21 gene mutation. You could have a combination of one or two of the bad one or the good one, and based on what combination of mutation that you have in the Oncotype DX test, they will be able to give you the risk of recurrent breast cancer. Another one is the mammoprint. They even go further than 21 genes. They look at 70 genes. The test mammoprint is not very practical because it requires fresh tissue, and unless you have a lab right in your institution, you can't send fresh tissue across the country. So it's not been used very much in America. So this is what the test looked like. The name has been crossed out. I just want to show you. So when I sent the tumor out to California, and I said, could you please identify the risk factor for my patient? And the test come back, it has on the horizontal line, that would be the score. And the score go from 0 to 100. And on the vertical line, it would be the interpretation of the score into the percentage of recurrent disease. This particular patient, her score is a 35, you see the circle 35, and that translates into a 23% risk of recurrent disease after she has a full surgery and after she's taking 5 years of tamoxifen. Remember, this test can be used only for estrogen receptor positive breast cancer. So if you look at an 80-year-old patient, 23% is not too bad, because if you look at the life expectancy, 83-year-old doesn't have as much life expectancy as a 50-year-old. For a 50-year-old, a 23% risk of recurrent disease is a big deal, because she will be living long enough that she probably will have recurrent breast cancer if we don't do additional treatment for her after surgery. So as this cartoon would say, we look at the patient factor, we look at where the patient at in the life cycle, how young, how old, comorbid condition, we look at the staging, we look at the molecular phenotype, the estrogen receptor, progesterone receptor, HER2 new status, we look at the prediction of response to specific treatment. That is coming later, but we're also looking at the risks that we have identified with the Oncotype DX to decide whether or not patient need chemotherapy. So first I'll talk about adjuvant endocrine therapy. So not all patients have to take chemotherapy. If you have estrogen receptor positive breast cancer, adjuvant endocrine therapy would definitely be recommended to you, whether you're premenopausal or postmenopausal. So what the options? Tamoxifen or the aromatase inhibitor. I usually say tamoxifen or 3 of the other newer drugs. That's what you probably hear. And the name are the anastrozole, letrozole, and exemestane. What's the difference between the two, tamoxifen and the aromatase inhibitor? Tamoxifen is basically a blocker of the estrogen. It's competing with estrogen. It's go in and block the estrogen from binding with the receptor on the cells, and by blocking the cell from seeing estrogen, it decreases the effectiveness of estrogen on the cancer cells. Whereas the aromatase inhibitor will reduce the estrogen production in the adrenal glands, in the fat tissues, and therefore decrease the effectiveness of estrogen on the tumor cells. We also can use ovarian suppression or ablation. For a premenopausal woman, their ovary is still making lots and lots of estrogen, so they can go through surgery. They can get hormone injection like Lupron that cut out the communication between the brain and the ovary and shut down the estrogen production altogether. So selection for premenopausal women, the only option would be taking tamoxifen or having the ovarian suppression with Lupron. For postmenopausal women, you have more choices. You can take tamoxifen, you can take the aromatase inhibitors. So tamoxifen inhibits cell growth by competitive antagonism of the estrogen receptor, and aromatase inhibitor decrease the plasma estrogen level by inhibiting or inactivating aromatase enzyme in your body. So what's the side effects? Now, we give this drug every day. I mean, I see so many breast cancer patients, many 80%, 85% of you end up taking one of these drugs. And what's the side effects? I'm listing out the side by side here so you can compare. With tamoxifen, the two most serious side effects will be thrombosis, increased risk of thrombus, and also uterus cancer. For the aromatase inhibitor, the risk factor will be osteoporosis and therefore early fracture. Both drugs can cause hot flashes. Both drugs can cause weight gain. That's because we change your metabolism. We change the effect of estrogen in your body. Tamoxifen tend to cause more vaginal discharge. Most drugs can cause sexual dysfunction, vaginal dryness, and the aromatase inhibitor, it does cause a slight increase of cholesterol, but there's no increase of mortality due to heart disease, so that's need to be kept in mind. So, if I see a patient, whether she is postmenopausal and she doesn't like the new aromatase inhibitor and want to be on the tamoxifen, I have to look at this list of side effects and decide if tamoxifen is appropriate. If she has history of pulmonary embolism, she has history of DVT, she has history of clot, she has a high risk of clot for sure, I'm not going to recommend tamoxifen. I would recommend aromatase inhibitor. If I see a woman who, even though she said, I have some feeling of hot flashes, I'm going through the change of life, but I'm still having menses every 3 months, she is not appropriate to take aromatase inhibitor. So those are the decisions that I have to make. So adjuvant endocrine therapy, we don't do combined therapy. Some patients are so zealous, they won't, why can't we take 2 of them? So one block and one decrease estrogen, no. We've done study, and the people who take both have less benefit than patients who take one or the other. So it's a single agent therapy. There is a theory about taking tamoxifen, then switch later on to letrozole or vice versa. There will be a theory about sequencing therapy, taking 5 years of tamoxifen and then take another 5 years. And those data are still accumulating. We don't have results yet. So right now, the therapy will be single agent. If tamoxifen, then you take tamoxifen 5 to 10 years. If aromatase inhibitor, you take aromatase inhibitor for 5 years. Here again, duration. Up until December of last year, the recommendation for tamoxifen is 5 years only. But the ATLAS trial that conduct in Europe show us the data that the woman who took 10 years of tamoxifen has decreased risk of recurrent disease 18% versus 21%, and mortality 30% less than the woman who only take it for 5 years. So the standard of care now for tamoxifen is 10 years. And we also look into, well, geez, you take 10 years of tamoxifen, are you going to have more clot incident than the 5 years? The clot incident is slightly increased, not terribly high. And the cumulative incident of uterus cancer is also slightly increased. The mortality is only 0.4% for the 10 years from uterus cancer and 0.2% for 5 years of tamoxifen. So if you look, I used to tell my patient this, if you compare 1 penny versus 2 pennies, they're double, but you're still looking at pennies. You're not talking about $1 here. So it's still acceptable to me. For aromatase inhibitor, again, 5 years is what we recommended. The impact of the extended therapy is still not known. I think within the next 5 years, we probably would have some recommendation. We'll keep you up to date on that. Although some of my patients, after they finished 5 years of aromatase inhibitor, and if they didn't have any side effects, their bone density looked good, and they said, I feel good, I usually said, take another year or two, be my guest. We'll continue to follow you anyway. So that's what most oncologists would recommend to do. if you do have side effects, if you have severe fatigue, bone pain, I don't think you need to stay on 5 years because we don't have data. So case 2, Jane is a 62-year-old retired school teacher, just diagnosed with metastatic breast cancer involving the bone only. She has excellent performance status, means that she can still go to work. She does everything at home for herself. Her tumor is estrogen receptor positive, progesterone receptor positive, and HER2 negative. So what should we do for Jane? Well, factors that influence the outcome and therapeutic option in metastatic cancer would include, again, the tumor biology, how extensive is the disease, the site of the metastases and the tumor burden, and the performance status of the patient and comorbid condition. The goal in metastatic breast cancer treatment is to prolong life, not to cure. Even though there's about 2% of these women that end up being cured. That was based on the data from MD Anderson. And the goal is to also alleviate the symptoms. This patient here has bone metastases. I'm sure she's going to complain of some bone pain. And treatment is to help her with the bone pain and maintain and improve her quality of life. So what can we do for this patient? Do we jump right into chemotherapy? Don't have to. Endocrine therapy, she has estrogen receptor positive. Why not give her something that doesn't take her hair away, doesn't take her energy away, and let her live fully instead of jumping right into chemotherapy? There is no data to say that endocrine therapy is less effective than chemotherapy. It's actually have much less side effects than chemotherapy. We do use chemotherapy when we have to, but I think for metastatic treatment, we pick the drug that has the least side effect for the patient. Sequential single agent versus combination chemotherapy. I don't believe giving chemotherapy for the patient to make them so sick that they cannot live. Remember, in this setting, patients take chemotherapy to live. They are not living for chemotherapy. If I give them treatment and they cannot get out of bed and just wait for the next week to go and get another dose of chemotherapy, then I fail the patient. Because my goal is to give the patient treatment so they can enjoy whatever time they have with their family, do what they like to do most, not to make them too sick. So I don't believe in bombarding them with left and right 2, 3 different kinds of chemotherapy just because it seemed like we're doing more. I think it's more of the anxiety of the doctors than anything else. There are times we have to do combining treatment modalities. I'm not saying combine chemo, many types of chemotherapy, but I'm talking about combine chemo with radiations or combine chemo with biological targeted therapy. So again, a list right here for metastatic breast cancer with estrogen receptor positive. You can take tamoxifen, you can take aromatase inhibitor, you can take estrogen receptor antagonist, etc. Now this cartoon right here, just to show you a little how complex cancer treatment is, and this is just for breast cancer, but it applies to all of the other type of cancer. You see in the bottom, in the middle, that is the nucleus where the DNA, all of the genetic information contained. And the outside that you saw there is the cell membrane. And the top one looked like Pac-Man up there. And basically the HER2 protein that is a transmembrane protein. And we now have several drugs on the right-hand side that listed there that specifically bind to this transmembrane protein and inhibit this protein to act in activation of the cancer cell to grow. And then inside the cytosol, the plasma of the cells, there's different pathways, the PIK3 and the AKT, the mTOR inhibitor, the RAS pathway. All of them, there are drugs that are being developed specifically to different pathways. All we're trying to do is cut off the transformation, the information from the outside world into the nucleus of the cells and therefore inhibit cancer cell growth. And that's called biological targeted therapy. some of these has been FDA approved, some of them are still in the process of being approved through clinical trial. So one of the examples that I want to bring up for breast cancer with biological targeted therapy is the valero 2 trials. In this trial, we used a combination of an aromatase inhibitor, which is exemestane or aromasin, and we added with the everolimus, which is an mTOR inhibitor. And in this trial, there were 724 women was randomized between either just taking the aromasin alone or taking the combination of the aromasin and the mTOR inhibitor. And we look at the survival. You know, it looked very dismal to you, but this is significant because the progression-free survival for women who take the combination is 7 months versus 3 months. That's more than double for them. And there's overall response rate, 9.5% versus 0.4%. Now, when you talk to an oncologist, these numbers are significant. We all want to have the 50% response, 50% improvement, but this is significant because remember, these people are hanging to their life, trying to live extra few months a year, and this is significant. There are added side effects, of course, when we add these medications: mouth sore, pneumonitis, inflammation of the lung, increased liver function. So another story of a drug called Avastin. Avastin is an anti-vascular epithelial growth factor. If you look at the cartoon number 1, pretend that was a tumor cells, and outside the tumor cells, there's always blood vessel growth. Tumor require blood supply. That's how it's grow, and it require more blood supply than normal cells. Avastin on cartoon number 2 basically is an antibody, and it specifically bind onto the receptor of these blood vessels outside the tumor. And when we did the experiment in the lab, we noticed that when these tumors was given, the cancer cell was given Avastin, the blood vessel disappeared. The cells is getting less and less blood supply, and they die off. Now, it was exciting. It was very exciting, and in 2008, the FDA actually approved this drug to be used in combination with Taxol for breast cancer treatment, for metastatic breast cancer. But then a few years later, they took it off the market. And what happened? Well, another group has performed the same experiment as the same trial, and they came out after the FDA said, yes, Avastin is very good, and it helped improve survival. A second trial came out and totally changed the whole outcome. Said, nope, we didn't see any benefit at all. We see side effects. So finally, the FDA said, okay, forget it. We're going to take it off the market. Drug is very expensive, not just the price, but also side effects. It can cause bleeding, can cause clotting. So they didn't feel that the benefit justified in this case. So what's wrong? I mean, there are definitely patients that respond to this type of therapy. So the problem is that not every one of these patients with metastatic breast cancer would respond the same to Avastin. There are selected group of women would have a complete response or a very high partial response, but there are people who will not respond. The problem is that we don't know what marker to use to figure out whose will be appropriate for this type of therapy. And that's our task, and we have to do more research. We have to figure out who is going to be able to use this drug, and hopefully one day this drug will be brought back to us in order to treat those women that would be benefit from it. There's another story of another biological targeted therapy, and this trial, I think some of you may still be on the trial. It's called the PEGI trial. This is a combination of the weekly Taxol chemotherapy with the PIK3 inhibitor. Remember the other cartoon? PIK3 is one of the other pathway that cells grow through. So if we give an inhibitor that inhibits cells signaling and then give the patient the chemotherapy, the theory is that we will double or more increase the response rate for the tumor. And this trial is still accruing. We see some great response through the phase 2 trial. That's why it is now a phase 3 trial. And I can't tell you what the response yet until we're done with the approval process. And Fergie trial, again, instead of chemotherapy, we use the anti-estrogen receptor therapy with the PIK3 inhibitor or placebo. We have trial in Europe using tamoxifen versus plus the mTOR inhibitor, letrozole versus the Avastin, so on and so forth. So chemotherapy, as I said earlier, usually for metastatic disease, we go with single type of chemotherapy, not double because of the side effects. And we also have to decide, who will be benefit. If you have a patient with a fast-growing tumor where you don't think the hormonal therapy is going to be fast enough to control the disease, then you have to go with chemotherapy. If you have a patient who has excellent performance status and very bad disease, aggressive disease, maybe they can tolerate chemotherapy. Those are the people that you would recommend chemotherapy to. So there's many names here. I don't want to bore you with all of this. Now let's talk about HER2/neu, because this disease deserves some recognition. During the last 3 years, there has been an explosion of options for a patient who has HER2/neu positive breast cancer. When I was in training 20 years ago, HER2/neu positive breast cancer dealing with very bad outcome. Most of these women, they metastasize very early and they die very early. Chemotherapy doesn't help them. With the new emergence of all of these new drugs that specifically targeted at these HER2/neu protein, first of all, the Herceptin, pertuzumab, lapatinib, TDM1, we see the survival of these patients is longer and longer, and we actually even use them in the adjuvant setting to treat them early before they become metastasized. So again, another cartoon here, the HER2/neu protein is a transmembrane protein. If you look at one of the drug called pertuzumab, it basically inhibits. In order for HER2/neu to become active, the HER2 protein and HER3 protein can dimerize. It has to bind together, and in order to activate the signaling system, so pertuzumab basically go in there and separate these two and block the dimerization, and that's how it's worked. Again, the same idea, pertuzumab, and so same as Herceptin that would do the same. Would have the same mechanism, but just different site of binding. So the bottom line for everything that I've been telling you, that treatment of breast cancer is not individualized. We used to think that, okay, if you have estrogen receptor positive, tamoxifen, that's not the case. If you have HER2/neu positive breast cancer, let's give you chemo. That's not the same. And it's not one size fits all. We have to look at the patient. We have to look at the tumor biology, and that's how we approach. And this is the trend, not only in breast cancer, but also in other type of cancer, colon cancer, melanoma. We look into the biology of tumor. We develop drugs that specifically target at those sites of mutations, and hopefully we'll be able to improve the survival of our patient as well as the quality of life of our patient. This cartoon right here, as you can see, all kind of new mechanism that how cell grows, and with each of these blocks, there is something in the future that's going to be attacking each one of these pathways, and that's going to be one day, if all of this, we can figure out which of these pathways for each of the patients that we have, then we probably conquer in taking care of cancer patients. Okay? So that's the end of my talk. It's very general, but I think that it gives you an idea of the scope of how complicated things are, and for us to make decisions, for the scientists to develop drugs. I think cancer treatment is not just about taking care of cancer, but it's also taking care of the well-being of our patients And that lead to the next talk that Carrie Jones, my psychic, my nurse practitioner that you all know and love, her talk about survivorship. This is one of the very new programs that's been promoting throughout the country. We are very good in giving patient chemotherapy and telling patients about chemotherapy, but we don't realize how devastating the cancer itself, just diagnosed with breast cancer or any type of cancer, is to the patient and their family. You all sitting here are all survivor. And survivor doesn't mean that you don't have breast cancer. Even if you have metastatic cancer, you sit here, you're a survivor. And we need to do more than just treatment to help you as a survivor. So Carrie is going to introduce to you the survivorship, and hopefully we are launching this program very soon. Carrie Jones.
Okay. Okay. It's nice to see so many familiar faces out here. I think survivorship is a very appropriate talk for this clientele here, because so many people here are survivors. Before we talk about what survivorship is, we first really need to define what a survivor is. And a survivor is anyone who has been diagnosed with cancer from the time that they are diagnosed through the balance of his or her life. And what's interesting about this is what Dr. Le-Lindqwister touched on is even someone who has been diagnosed with incurable cancer is still a survivor from day one. Some facts about survivorship, and this is just survivors in general. This isn't just breast cancer, this is all cancers. In 1971, we had only 3 million cancer survivors nationwide. In 2001, that number had grown to 9.8 million. By 2007, it had jumped again to 11.7 million cancer survivors. And our most recent statistic was in 2012, where we had 13.7 million cancer survivors. Now, what's really interesting is that by 2022, we know this number is going to grow, and in fact, they predict it's going to be 22 million cancer survivors nationwide. That is wonderful. Some more facts. 64% of survivors have survived 5 years or more from their diagnosis. 40% have survived 10 years or more, and 15% have survived 20 years or more after diagnosis. Now, that last little statistic doesn't sound as impressive, but then when you go to the next line down, and we see that 59% of our survivors are currently 65 years of age or older. So there could be other issues like heart disease that are taking our patients and not necessarily cancer. The last bullet talks about our survivors, the breakdown. And of all of our survivors, they look at the different cancers and where we fall into it. And you can see breast cancer accounts for 22% of our survivors. Then we go to prostate at 20%, colorectal at 9%, and our gynecological at 8%. And I didn't break it down any further, but we have all of our cancer diagnoses are represented. Why do we have the increase in survivors? Well, first off, we have earlier detection. We have improved diagnostic methods. We have more effective treatments, and Dr. Le-Lindqwister touched on that briefly with breast cancer, and that really was briefly. There are so many different advances they have with breast cancer, and improved clinical follow-ups after treatments. Cancer survivorship is a distinct phase of the trajectory of cancer care. At the end of active treatment, many survivors often have mixed emotions, including relief that their treatment is over, as well as anxiety about the future. After treatment, the safety net of regular, frequent, sometimes weekly and sometimes daily contact with the oncology team ends. Some survivors may miss the source of support, especially because anxieties may surface at this time. Others may have physical problems from their treatment, psychological problems, sexual problems, fertility concerns. Many survivors feel guilty about surviving, having lost friends or loved ones to the disease. Some survivors are uncertain about their future, while others experience discrimination at work or find that their social network is no longer adequate. So at Illinois Cancer Care, we're getting ready to pilot a survivorship program. It's going to start in our Peoria office, and it's going to start with our breast cancer patients, and we hope to roll it out this fall. But as that becomes more successful, we're going to try to encompass all of our different survivors. And of course, we're going to bring that to Pekin as well once we can get things rolling in Peoria. We understand that there is a life after cancer, and we want to optimize everybody's health and improve the quality of life in everybody. So, some essential components of survivorship. It's through a lot of research that included looking through journals and also talking to patients that was determined that a survivorship program really needs 4 components. The first part is prevention and early education. The second part is surveillance of cancer. Third part is interventions for side effects of cancer and the cancer treatment, and then coordination of care. So if we take a closer look at these 4 steps. Step 1, prevention and early detection of cancer. We do this mainly through education and through cancer screening. With education, it's important to talk to our patients about ways we can reduce the risk of other cancers. We know that diet and exercise is important. We know that obesity is linked to an increased cancer risk. So when we talk to you about trying to get to an optimal health, we're really just trying to help prevent that cancer risk and of course cardiovascular risk and other health benefits from it. Sun exposure is key. We want to reduce the risk of skin cancers and melanomas. And talking to everybody about alcohol and tobacco use. Of course, limiting your alcohol intake is best, but we also want to try and get everybody to stop with smoking. With cancer screening, it's still important to keep up with pap smears and mammograms and colonoscopies. Sometimes I think that we have patients who maybe think because they had a cancer diagnosis that it isn't possible to get another cancer diagnosis, but it is, and we got to be vigilant with our other screenings. Step 2, surveillance of cancer, and this is what Doc and I already pretty much do. After you've been through treatment, we see you at a regular interval, and we do lab work, including tumor markers. For some of you, some of those numbers might look familiar. The CA27-29 would probably apply to a lot of different people, and that's breast cancer marker. Many of you have heard of the PSA for prostate cancer. Well, we do have cancer markers for other organs that we can follow. In addition, when appropriate, we can do scanning, PET scans, MRIs, CAT scans, bone scans. And then, of course, every time we see you, we're asking you, how are you doing? And we're wanting to know what kind of side effects that you're having, if there's new pain, if there's shortness of breath that's new. Those are all parts of the things that we look at to figure out how you're doing in terms of your cancer and making sure there's no signs of it. The next step is something that would also apply to a lot of people, and this is looking at the side effects of cancer and cancer treatment. Physical long-term side effects. Now, they define long-term side effects as any side effect or complication of treatment for which a patient must compensate. These begin during treatment and continue beyond the end of treatment. So examples are fatigue, neuropathy, which is numbness and tingling in the fingers and toes, which is a common side effect of a lot of different chemotherapy drugs. Cognitive dysfunction, or rather cognitive function, but rather cognitive dysfunction, because some people can have some memory changes after going through chemotherapy. Chronic pain, decreased mobility, weight gain, and sexual dysfunction. We have physical late side effects. Late side effects are absent at the end of therapy, but can manifest years later. That's osteoporosis, so Doc and I will follow people's bone density scans when appropriate, lymphedema, cataracts, lung disease, cardiovascular disease, and infertility. And then lastly, we have the psychosocial side effects. Depression, fear of reoccurrence, anxiety, isolation, altered body image. With altered body image, we have lots of patients who have had mastectomies or lumpectomies or colostomy bags, and that's learning to live with their body as it is in a new presentation. Changes in interpersonal relationships. We've seen marriages kind of fall apart as patients go through treatments. Concerns about finances. Obviously, treatment can be very expensive. Job loss, spiritual issues. And finally, step 4 is just connecting our patients to resources. So first is primary care and trying to keep them in the loop. Because when patients are going through active treatment, we tend to kind of monopolize the patient because we're seeing them so often. But once we're through regular chemotherapy appointments, then getting that patient back to primary care to kind of look at the person as a whole, since we tend to look at patients from the cancer standpoint. Also, we do have patients that would benefit from physical therapy after chemotherapy is over. Even something simple as side effect as fatigue can make somebody less likely to be mobile, and then less you move around, less those muscles can move around. So physical therapy has actually been very important for some of our patients. Dietitian. We have a dietitian in the Peoria office, and we're so fortunate that we now have somebody regularly coming to the Pekin office. I saw her briefly today, and she's going to be coming back tomorrow, helping to work with patients as far as getting that optimal diet, and when patients are on treatment too, trying to help them so that they can maintain their weight. And then psychologist / psychiatrist / counselor, and I didn't put this on here, but support groups too. It's important to take care of the mind just as much as we're taking care of the body. So I want to leave you with our mission. Illinois Cancer Care's mission towards survivorship. Our mission is to utilize a multidisciplinary approach to address the outcomes of cancer and its therapy, and to improve our cancer survivors' health and quality of life through integrated programs in patient care, both physical and psychosocial needs, prevention, research, and education. And thank you.
Okay, any questions? Anybody fill out their card and have questions? Everyone went so bashful. Anybody else? No? No, I didn't think this was such a bashful group earlier when they were all talking.
Maybe we answered everybody's
Maybe answered.
questions.
They did such a good job, you don't have any questions.
First question, how long have you been sending results to lab in California? Are you talking about the Oncotype DX test?
I think the tumor markers have
Tumor
been coming,
marker?
the 27, 29 have been coming from California, somebody told me that. But I think that's a Pekin Hospital.
Yeah, and you know, the tumor marker, as far as where it goes to, really is not our decision. The patient go to Pekin Hospital. If Pekin Hospital has a contract with the Mayo Clinic, that's where it goes to. Or if they have contract with San Diego or someplace close by. So these tumor marker these days are very easily done. In our office in Peoria, we do it right then and there. So I'm not sure if I'm answering your question. The second question, if you don't have tonsil for several,
If you don't have tonsils or several lymph nodes are gone, does this make you more susceptible to get cancer again? Oh, if your lymph nodes are missing, you have tonsils.
and how important is your good bone marrow to fight
Fighting
cancer?
cancer.
Well, number one, you don't have to worry about fighting cancer without the tonsil, because you have lymph node everywhere. So the lymph node, it's just basically a resting station for the lymphocyte, the white blood cells there. So it really does not affect your immunity. So you're not susceptible for getting cancer again just because you don't have your tonsil. So that's the answer. And how important is a good bone marrow to fight? Well, in younger patients, if we give the chemotherapy, they most likely will be able to continue with chemotherapy on time. In older patient who has more comorbid condition, sometimes we have to delay chemotherapy because the bone marrow, just like anything else, it will take longer to recover, and time is the only thing that can help. So the answer is young versus young and healthy is definitely doing better than old and not healthy bone marrow. So how do I find out about clinical trials? You can find out, we have our website on our Illinois Cancer Care website that you can find out about clinical trials. There are two different types of clinical trials. Treatment trials, say drug A versus drug B, and usually the physician would, myself or Carrie would discuss with you, say, well, we find that you may be eligible for this trial, would you like to participate? And the second type of trial is called cancer control. Mainly it's not about drug A versus drug B, but basically treatment for your symptoms. We had a trial for hot flashes, and you will take a vitamin this and vitamin that to help you with the hot flashes. We have neuropathy trials where we use Cymbalta versus placebo. So those are the cancer control. You know, with the change in the economy, I think we're going to see less and less treatment trial with the NCI because the funding is so low, but we're going to see a lot of focus onto cancer control, so symptom management in the future. So
Also, there is a website called clinicaltrials.gov where you can search by disease site, like breast cancer or colon cancer, and it will give you a list of clinical trials happening throughout the entire country. So you can find whether we have a study open at Illinois Cancer Care, or if there is, one at University of Chicago or MD Anderson, and that's something that you can bring up to physicians, or just if you want to do some research at home. It's clinicaltrials.gov. You can search by drugs, you can search by disease site, you can search by specific studies that you've heard about. So our patients seem to like that one. It's pretty user-friendly.
And whenever we see you, we're kind of going through our head based on the side effects you tell us. Hey, yeah, she's talking about neuropathy. We have that neuropathy study, and then I'm running into my office and looking to see if they qualify. So we try to keep those in mind when we're seeing you too.
We have a very, very active group of clinical research assistants. They basically, before I get to see you that day, and if they look at your scan and they look at the drug that you've been through and the side effects, that they look from my notes, they already screened the chart and said, these ABC trials is what you need. So I'm very lucky to work in the environments that I, sometimes don't remember all of these trials. We have at any point in time over 100 trials. How could you remember all of this? And the CRA, they do screen the patients, and they put a little note in there in the blue slips that said the patient is eligible for this trial. So I will go back and look at it and see if this is appropriate, and then if it is appropriate, I will talk to the patient. Sure. Okay, is a breast cancer recurrence in the same breast with a different type of cancer considered a new cancer or the recurrent? It is a new cancer.
Any other?
I didn't
Sure.
write it down, but is there a team that you work with after you identify the cancer and to come up with the treatment? Is there a team, or is it?
For the breast cancer group, we have 3 physicians right now in the group that see all of the breast cancer. And we do talk to each other. We don't look at all of the cases, but cases that unusual, that has complications, complicated details, and nobody really knows. We consult among ourselves. We also have support from physicians in the academic center that we call and ask them for opinion, or I send my patient to get a second opinion if I don't feel comfortable about the decision. So we work as a team, and physician from our group, other physicians that they don't treat breast cancer as often, they constantly call us and say, what would you do in this case? Somebody who see patients, say, in Ottawa and only see breast cancer once or twice a year. They don't see as many as I do. They call me and said, well, would you recommend the patient do this and that? Yes. So in a sense, we do have a group that we discuss about.
I too didn't write this down. Carrie, could you mention a little bit more about the rollout of the breast cancer survivorship program this fall?
Yeah, so right now our date is tentatively August. We've been trying to work on space in the Peoria office first, and kind of the dynamics of how we're going to do it. So we've been meeting almost monthly discussing this. But like I said, it'll start with our breast cancer population first, and it's going to be our patients that get seen once a year. The nurse practitioner, there'll be 3 of us that are part of this program, and then Dr. Le-Lindqwister and Dr. Prager are the 2 physicians that are overseeing it as well. And we're going to sit down, and actually the first appointment with the patient is blocked for a potential hour long. That way we have a chance to go over, and that was those 4 steps. Those are really all the things we're going to see. The big thing that came from this was noticing our patients who have long-lasting effects from treatment, and how can we make that as good as we possibly can. And then once we figure out what all these different long-lasting issues are, and then even discussing with the patient, because I had learned, I'd gone to a conference in California, and they had some patients that were interviewed, and I was surprised at how many of them didn't even remember the name of the drug they had received, and they had just were so overwhelmed when it was all rolling out. They don't remember what their stage was or why we chose this. So part of it's just going to be sitting down going, this is when you had your surgery, this is what you had done, this is what your stage, and explain it all, just kind of backpack and give a patient a written piece of paper that has this information down so that they always have what chemo they received or what drug they were on. And then, like I said, talking to them about possible side effects that are still going and how we can make those better.
Okay, thank you. Our goal is to be able to start survivorship immediately after you see the doctor. Because even if you start chemotherapy, you are a survivor. You're going to need to have that information. Right now, since it's starting, we're going to start out with it 1 year, and then hopefully within a few months, we're going to move in and start seeing more patients. The 6 months follow-up, the 3 months, or even the people that get treatments and continue with the program. I have a question here. Want to know about dietitian and psychology. The dietitians that we have right now, they're provided by the Center for Healthy Living. We have 2. Psychological help, we have 2 people, right?
Yeah. Kitty.
Kitty's with Hope, isn't she?
Hope, yeah. As a need, we have to find out what the need is for all of these services. If the need is increasing and we need to hire more or getting more help, we may ask our foundations, to fund and help from the community. I dream of having a big day of cancer survivorship clinic where I would be able to have the people from physical therapy to be there, and then the nutritionist, and then the psychologist, and then the patient come in, see us, and then we identify, say, you need to see the nutritionist, and we ship them to the nutritionist. So it's all in the same day. Right now, with the cancer center being expanded and we're not sure how the space is going to take, and so we're just going to start out with seeing us, and then we refer you to different places, and we have all of this information for you. Some of our MP has already been getting training, say sexual dysfunction. Nobody want to talk about it. Really, I see all of these patients. The only time they'll talk to me about sexual dysfunction because the treatment is when I ask them. Nobody come in and say, well, listen, I have this problem. Nobody. So one of our MP is being trained right now, and she's going to be very well versed, and she's going to talk to you and options of what to do. That's part of life, and that's how we improve your quality of life.
And then, of course, while it starts with breast cancer, then we're going to go and collect all the disease sites. So eventually, this is going to be a very busy clinic.
No, and I cannot see how 3 NPs going to be able to see all of these
We
patients.
have a second shift.
But we have to start small first because it's too overwhelming with getting everybody in. Well, I thank you for spending the time with us today. I want to congratulate all of you who's sitting here because you have to be a survivor to be here. Some of you are doing very well. It's everyday living is a gift. Yeah.
Amen.